Right. The radiological modalities in neuroimaging, we use X-rays, CT scan, and MRI. X-rays are easily available. They are cost effective and they're fast. They are basically used to outline the fractures, to identify the fractures in the skull and the spine. Obviously, in X-rays, we do not get any information about the brain and the spinal cord. All we can see are the cranial bones and the vertebral column. Two important views are performed when we are doing X-rays, whether it is a cranial X-ray for the skull or we are doing spine X-rays. The two views are AP, which is anteroposterior, and the other view is the lateral view. This is an AP view of the skull, and there are a number of structures which are identified here. You could identify a sagittal suture, the lambdoid suture, the crista galli, the supraorbital margin of the orbit, and the petrous temporal ridge. This is the lateral view of the skull, and again, you can identify various points here. The frontal bone, the coronal suture, the vertex, the lambdoid suture, the clivus, pituitary fossa, the posterior clinoid process, ethmoidal air cells, frontal air cells, sphenoid sinus, maxillary sinus. So basically, as a general rule in radiology is that whatever part you examine in two views. This is a small pathology where you could identify a fracture in the skull of a child. You could see that this is a fracture line, which is indicated by an arrow. And you can again identify this fracture on the AP view. This is the X-ray, plain X-ray of the cervical spine. As you realize that spine is divided for anatomical reasons into three regions: the cervical spine, the thoracic spine, the lumbar spine, or you could call it as a lumbosacral spine, which also includes part of the coccyx. So this is the cervical spine X-ray, and there are again two views. The AP view is this view, and then we have the lateral view. There are a number of structures we identify. When you're looking at the spine, the first thing you need to see is that there is no rotation. You identify that there is no rotation, particularly when you look at the clavicles. They are of equidistant from these teardrop-shaped structures, which are the spinous processes. You're looking at the spinous processes in the AP view, and they appear as teardrop. They are equidistant, so the patient hasn't been tilted, the patient hasn't moved, the patient isn't oblique. And on the lateral view, you identify that the vertebral bodies are all aligned, right? There are a number of lines you need to identify in cervical spine X-ray, and these are curved lines. And if you draw a curved line from this margin, as the cursor indicates here, I'm trying to draw this arbitrary line, you would see that there is a smooth curve in the cervical spine. The second line is this line, which is along the posterior margin of the vertebral body. Again, this is a smooth line. The third line is along the anterior margin of the vertebral bodies, right? Now, the distance between this posterior margin and this line of the spinous process is the spinal canal. But you don't need to worry about it at this stage because you don't need to identify the spinal canal on plain X-rays. All you need to do is the major abnormality, if any vertebra has moved forward or backward, or if there is a compression fracture in the vertebral body. This is some pathology regarding the cervical spine. There is a small fracture in the anterior inferior corner of C3 vertebral body. This is indicated by this arrow. You could see that the vertebral bodies are not malaligned, but there's a small fracture here. On the second X-ray, you could see a fracture of the spinous process. On the third one, you could identify the malalignment. If you could see that this vertebral body hasn't moved, it is the vertebra on top which has moved forward. So there is enterolisthesis. There is a slippage of the vertebral body above. These are lumbar spine X-rays, and again, these are identified lumbar vertebral bodies right up to S2. This is an AP view, and the arrow indicates the facet joints, right? This part is the sacrum, as it is labeled as S1 and S2, and this part on the AP view is the sacral part, which is being joined by the two innominate bones forming a pelvis. A bit of pathology again regarding lumbar spine. You could see that there is compression fracture. Now, if you count from the bottom, this is lumbar 5, lumbar 4, 3, 2, and 1. And here you could see that the vertebral body has lost its normal square-shaped appearance with anterior compression or anterior wedging. And this is a compression fracture. Now, CT scan is an important modality in radiology, and it is a cross-sectional imaging, and it can be used for head. Again, with current CT scanners, which is a multi-slice CT scanner, these images can be reconstructed from the axial plane into coronal plane and even in sagittal plane. The advantages are it can visualize brain parenchyma. The brain parenchyma shows shades of gray. The bones and any calcification and acute blood appear white or hyperdense. Fluid, fat, and air appear black or hypodense. It is used to image brain, and on bone window settings, we can diagnose fracture looking at the bones. I'll show you the examples in a few minutes. Right, this is an axial image of normal anatomy of CT scan. Sorry, I'll move back. Yeah, what you could see is that these are the two orbital areas. These are two eye globes. This is an optic nerve. This is the pituitary fossa. This is the sphenoid bone. This is the temporal lobe, petrous temporal bone, the mastoid air cells, pons, fourth ventricle, and cerebellum. This is the magnified image of the axial image. And here you can identify that this is a sulcus, which is outlined in blue. This is a gyrus, which is outlined in green. In between the black area is the CSF. The white rim is the skull, and it is the calcium which appear as white, and various shades of gray are used to indicate the brain parenchyma. Now, this is an axial CT scan image. And on this is the anterior horn of the lateral ventricles, the posterior horn, and this is a normal image. And this is again a labeled image indicating the anterior part of the corpus callosum called the genu, the posterior part of the corpus callosum called the splenium, the internal capsule, which is marked with an asterisk indicated with blue color. This is again an axial image, and the blue color is the caudate nuclei. The orange one is the lentiform nuclei, and the green one are the thalami. Another axial image. This is the cavity of the lateral ventricle. This is an unlabeled image, and on the labeled image, I've marked it with blue color for you to easily identify it. The white bit is the calcium. in the choroid plexus, which is indicated with yellow color. Again, on another image, you could see that this is the left cerebral hemisphere. This is the right cerebral hemisphere. The green color actually indicates the tentorium cerebelli, and the pink color is the cerebellum. On this image, this is slightly lower image than this one. This is the posterior fossa. This houses the cerebellum. Anterior is the brainstem. The brainstem is composed of midbrain, pons, and medulla oblongata. And posterior to the brainstem is the cerebellum, right? And then these are again a few labeled points. The frontal sinus, this is the pituitary fossa, this is the in pituitary infundibulum. And on the next image, we look at the same image, but on a bony window. When we say the bony window, what it means is that the brain parenchyma is masked totally, and what you can look at is the bone, which is the skull bone. So this is the frontal bone, which is marked as number 3. This is an anterior cranial fossa marked at 4. This is the sphenoid bone marked 2. Number 1 is the middle cranial fossa. Number 5 is the external auditory canal. Number 6 is the petrous temporal bone. Coming to MRI, it is a modality which is fairly commonly used these days, but it is slightly expensive to use. Again, advantages are multiplanar imaging of the brain, and these images are obtained on various planes without reconstruction. So it's not computer calculated image, but it is in actual obtained in that plane. It has an excellent gray and white differentiation on MRI for brain parenchyma, better visualization of brain parenchyma, vascular structures, and cranial nerves. There is poor visualization of bones and calcification. This is an important point for you to remember, that on MRI, there is poor visualization of the bone and calcification. These are MRI images, and now you can identify that, that on MRI images, there is poor visualization of the skull bone. It appears as black, right? Now, the brain parenchyma and the brain anatomy is pretty much the same, obviously. These are orbits with 2 eyes. These are lenses. You can see it better on MRI. Again, this is the brainstem. This is the cerebrum, left cerebrum. This is the right cerebrum, and a little bit of cerebellum on this image, right? The axial images are pretty much the same, but it's just a different shade of gray when you compare it with CT. This is, on this axial image, you could see more of the posterior fossa. This is again the pons. The way to identify pons is, pons in Latin means bridge. It's 13 hours. And when you look at the pons on this image, it looks like a bridge, which is connecting the 2 cerebellar hemispheres. A bit of pathology regarding brain. Intracranial hemorrhage can be extravascular accumulation of blood within different cranial spaces. The acute hemorrhage is hyperdense. It appears white on CT. With passage of time, density decreases and becomes hypodense black. So when it is chronic, when the blood becomes chronic, it becomes black. When it is acute, it becomes white. Intracranial hemorrhage can be divided into intraaxial, intracerebral, and extraaxial. When you talk about intraaxial, it basically means any blood which is within the brain parenchyma is intraaxial. is just a fancy word to indicate that the blood is actually in the brain. So it can be hemorrhage within the basal ganglia, within the lobes, within the pontine, within the cerebellum. The extraaxial means that any blood which is outside the brain, but within the skull. So it could be extradural hemorrhage, which means outside the dura mater. Subdural hemorrhage, which means that it is beneath the dura. Subarachnoid, beneath the subarachnoid membrane, and intraventricular hemorrhage within the ventricles. Now, looking at this hemorrhage, this is a hyperdense area which is in the region of the right lentiform nucleus. This is an acute bleed, and again, as I've mentioned before, that it appears hyperdense. This is an intraaxial, intracranial. Looking at this image, you can see that there is hyperdense blood, fresh blood, lying within the base of the brain. Now, this is within the basal cistern. You could see that there is a hyperdense blood within the sulci. These are the sylvian fissures, and it is in the subarachnoid space. On this image, you could see a crescentic hyperdense border along the right cerebrum, and this is a subarachnoid hemorrhage. And on this image, you can see that there is a biconvex accumulation of hyperdense blood, and it is along the right parietal bone. This is an acute extradural hematoma. This usually happens with the presence of a skull fracture, and this is indicated with a soft tissue swelling overlying the fracture. So there must be a trauma. Intracerebral hemorrhage, presence of blood within brain parenchyma. Most common cause is hypertension. Other causes include vascular malformation and trauma. Commonest site of hypertensive bleed is basal ganglia. Intracerebral hemorrhage. Again, as I've shown you before, that this is acute blood. This is in the region of the left lentiform nucleus, and while reporting, somebody has measured it as well. This is surrounded with this black vasogenic cytotoxic edema. This is causing compression and mass effect over the left lateral ventricle with slight midline shift. If you draw a straight line from anterior to posterior, you would see that the midline septum is slightly deviated to the right side. Extradural hemorrhage. This happens in cases of trauma. It appears hyperdense, white, and biconvex in shape, as I've already shown you. Extradural hemorrhage, usually associated with fracture of the calvarium and hematoma of the scalp. We have already discussed that. Again, I'll show you. This is the same image as I've shown you before. Extraaxial, extradural acute hematoma associated with a right parietal bone and right parieto-occipital bone fracture, associated with soft tissue swelling, as you can identify here, and this is scalp hematoma. Right, subdural hemorrhage is hyperdense. It is basically crescentic shape. It is easy to remember with crescentic shape or semilunar in shape, and it's usually seen in elderly people. Right, this is the various stages of subdural hemorrhage. Here you can identify it as hyperdense area, which is again crescentic shape like a moon, semilunar. This is acute, hyperdense, so it is acute. This is going towards chronicity, and you could see that half of it is black, half of it is whitish, and the white area is settled posteriorly. Patient is lying supine, so it is heavier blood, it is acute blood, it is settling posteriorly. And on another image, you can again see this is all chronic subdural collection or subdural chronic hemorrhage, and it has all gone dark because of the chronicity. Subarachnoid hemorrhage associated with trauma or rupture of the aneurysm. It is hypertense blood in the sulci and the basal cistern. I've already shown you another image of the same. You could see the hyperacute blood within the anterior interhemispheric fissure, within the sylvian fissures bilaterally, and this is subarachnoid hemorrhage. If it is associated with trauma, then it is traumatic subarachnoid hemorrhage. If it is spontaneous, then you need to look for aneurysm. Intraventricular hemorrhage is the presence of blood within the ventricular system, primary due to hypertension. It could be due to AVM or rupture of the aneurysm. Secondary, there's an extension from other hemorrhages like basal ganglia bleed or subarachnoid bleed. That blood can also be accumulated within the ventricles. This is intraventricular hemorrhage, where you could see that the acute blood has been accumulated within the body of the lateral ventricles bilaterally. Whereas in this case, there is a large parenchymal hematoma or acute blood in the region of the left thalamus, which is dissecting into the ventricular system. As it is compressing the left lateral ventricle, it is dissecting into it with accumulation within the ventricular system. Now, talking a bit about stroke. A stroke is a medical condition in which poor blood flow to the brain results in cell death. There are two main types of stroke: ischemic, due to lack of blood flow, or hemorrhagic, due to bleeding. The result is that the part of the brain involved will not function properly. The goals of CT in acute stroke settings are, basically the point is to exclude intracranial hemorrhage, which would preclude thrombolysis, identify early features of ischemia, exclude other intracranial pathologies that may mimic a stroke, such as a tumor. Now, what are the features of stroke on CT? As I've mentioned before, there are two types of stroke: ischemic stroke or hemorrhagic stroke. In ischemic stroke, due to sudden cessation of adequate amount of blood, the ischemic stroke can happen, and it is divided according to the territory affected, right? Like if there is acute cessation of blood in the anterior cerebral artery, in the middle cerebral artery, or in the posterior cerebral artery. So depending which artery is involved, that area would be suffering from ischemic stroke. CT scan shows low attenuation area in the involved territory due to edema with loss of gray and white matter junction. In case of hemorrhagic stroke, you would see a hyperdense area of abnormality within this region, and in majority of these cases, it is associated with hypertension. About 60% of hypertensive hemorrhages occur in the basal ganglia. Other areas involved are thalamus, pons, and cerebellum. All right, this is an ischemic stroke. In this scan, you can identify there is a hypodense area posteriorly in the left cerebrum. Over here, there is a subtle abnormality. You could see that the sulci on the left side are easily identified, whereas when you look on the right side, the sulci are effaced. You can't identify, they are edematous, and you can see a faint wedge-shaped area in the region of the middle cerebral artery, which appears darker than the remaining brain parenchyma. So this is an acute ischemic stroke in the territory of the right middle cerebral artery. Sorry. This is hemorrhage in the region of the left thalamus. So this is hemorrhagic stroke. Again, I could show you here that this is dissecting into the ventricular system, and there is blood accumulation within the ventricle, which is lying posteriorly. Now, MR features of stroke. MRI is modality of choice in acute ischemic stroke, but not hemorrhagic stroke. Hemorrhage is better identified on CT, but not very well on MRI. Ischemia is very well identified on MRI, but poorly, as you have seen before, is poorly identified on CT. It can be identified, but within the first 12 hours, it will not be identified. You need to remember that if there is an acute ischemic stroke, and if the symptoms are less than 12 hours, you will not identify anything on CT. It will appear completely normal, whereas you can identify that on MRI. There is a special image on MRI, which is called diffusion weighted MRI imaging. It is a type of sequence which MRI machines can perform and can pick stroke within hours, even when CT appears normal. Ischemia appears hyper-intense, white on DWI. DWI are the diffusion weighted images. Now these are DWI images at the bottom. You could see that this area, which is in the distribution of the left middle cerebral artery, appears white. Now this is an acute ischemic stroke, and this acute ischemia is indicated with high signal abnormality in the left parietal cortex and deep white matter. Same patient on T2 weighted image. This is the T2 weighted image of the same patient. It is very difficult to identify it, almost impossible. Right, in case of head injury, CT is the first modality which should be used. It allows rapid assessment of brain pathology, which ensures patients who require urgent surgical intervention. If there is a lot of blood accumulation, there is a danger of coning. Obviously, it's a surgical emergency, and the CT is rapidly readily available. It is quick to perform CT scan brain. So that examination is the first modality of choice. CT scan can demonstrate extradural, subdural, or intracranial hemorrhage and midline shift, or traumatic subarachnoid hemorrhage and ventricular abnormality. We have discussed all of this. Now coming to diffuse axonal injury, DAI is a frequent finding after traumatic brain injury, TBI, accounting for up to 50% of trauma patients. CT scan may remain normal in such cases. The region of the brain that are commonly injured include the gray and white matter interface, corpus callosum, deep white matter, periventricular and hippocampal areas, and brainstem. Such regions are best visualized using MRI. It is difficult to identify on CT, but easy to identify on MRI. Diffuse axonal injury. Now, this is a patient, this is the CT. You could see that there is a loss of the gray and white matter differentiation. You could hardly make out a difference between the cortex and the deep white matter on these images, whereas on MRI, you could easily identify small areas of abnormality, and this is indicating again in the region of corpus callosum, anterior to the corpus callosum, and it indicates diffuse axonal injury. Now coming to brain tumors, CT can diagnose cerebral tumors, superior in showing tumoral calcification and hemorrhages. MRI is far more superior due to its better contrast resolution. I'll show you some examples. When we evaluate for brain tumor, the important points to consider is the age, the location of the lesion. Is it intraaxial, extraaxial, or which anatomical compartment? It is a single mass or a multifocal mass, and this characteristics on CT and MRI. Most brain tumors are of low signal intensity on T1 weighted images and high on T2. The differential diagnosis of a tumor would be an abscess, an MS plaque, vascular malformation, aneurysm, or an infarct. This is the same slide. Right. Now, CT versus MRI and brain tumor. You could see that there is a mass effect in this region of the left frontal region with a speckle calcification. This is the same patient with MRI examination. You could see easily identify the abnormal area. You could see that this abnormal area on following contrast is inhomogeneously enhancing. It is causing a mass effect. It is causing compression of the left lateral ventricle with midline shift towards the right side. Another case where you could see that there is a big tumor on CT scan in the region of the third ventricle. When given contrast, this mass is clearly enhancing and it is causing obstruction with developing hydrocephalus. You can see that the ventricular system is all dilated. These are MR images of the same patient. You could see the mass here, enhancing with contrast again. And on the coronal image, you could see that there is developing hydrocephalus. Another mass lesion. This is in the region of the posterior fossa, right CP angle. Again, this is on MRI. When you magnify it, you can identify a small vessel. You can identify that this has an encasing or a capsule around it. So MR gives better detail, more detail than CT would provide. But CT would be faster and MRI would be a time-consuming examination. Advantages and limitations of diagnostic tool in evaluation of brain tumors. X-ray nowadays do not play any role in case of brain tumors. CT scan is usually the first investigation. As I've said, it's fast, it's readily available, it's cost effective. If there is any immediate surgical action required, it can be decided on easily. Better visualization of the bone involvement by tumor, particularly in the region of the skull and around the bony orbits. Again, better visualization of the tumor. If there is calcification within the tumor, if there is a bleed within the tumor, again, that can be identified and the surgical planning can be easily done. Advantages and limitations of MRI in brain tumors. MRI is usually done following CT. Once the CT has confirmed, or if there is a suspicion on CT, MRI is performed. It is the modality of choice. Why? Because it gives fine detail and again helps for surgical planning. It will also identify if there are vessels involved in the circle of Willis, in any of the cranial nerves involved. If there is a suspicion of the brain tumor, whether it's benign, malignant, there is another sort of a sequence or different examination performed under MRI, and that is called MRS or MR spectroscopy. There is a new modality, there is not a new modality, but it is the same MR modality, but a different way of performing examination, which is called MR tractography. And it basically outlines the cracks, the cranial nerve cracks, so that when there is a tumor, you could tell that after surgery, what sort of cracks would be involved during surgery and what sort of loss of function would be there following surgery. MRI has limited visualization of calcification, bleed, and bone, and it's difficult to identify calcification, bleed, and bone on MRI. Right, X-rays can show skull fractures. Coming to the advantages of X-rays, it can show skull fractures, but in suspected spinal injury, it is the first line of investigation. Why? Because again, you can easily identify if there is any vertebral body which is shifted, which is displaced. You can see that there is malalignment. X-rays are easily available, they are fast and cost effective, but it will not provide any information of spinal cord and the cranial nerve. CT scan modality is a modality of choice in head injury. We've already dealt with head injury again. Evaluation of hydrocephalus. X-rays has no role. CT is important, can diagnose presence and sometimes cause of hydrocephalus. It is good for follow-up after shunt placement. MRI provides similar details, but it is more expensive. Now, a few images regarding the spine. This is a sagittal image, which is a reconstructed image in CT. You could see that the calcium and the bone is appearing white and bright, and we can see the thoracic spine, the lumbar spine, the sacral spine, and a bit of coccyx here at the bottom. Cervical spine, C2, C1. Once you identify it, you start counting 1, 2, 3, 4, 5, 6, and 7. Between 5 and 6, you can see degenerative change with reduction in the disc space. This is an axial image of the cervical vertebral body. How do you identify that this is a cervical vertebral body? You identify it when you see a foramina for the vertebral artery. That foramina for the vertebral artery is only in the cervical vertebral bodies and not in any other vertebral body. This is a thoracic spine and the thoracic vertebral body. Again, they are fairly well aligned, smooth curves in the thoracic spine vertebral body. How do you identify thoracic vertebral body? You would see ribs on either side of the thoracic vertebral body. Like in this case, you could see this rib on the left and the rib on the right. This is the spinous process, and that is how you identify thoracic vertebral body. Coming to the lumbar, there are no ribs attached in the lumbar vertebral body. They are 5 in number. They are more broader and wider vertebral bodies than the thoracic and the cervical vertebral body. A bit of pathology following trauma. This is a sagittal image of a CT cervical spine. You could see that there is enterolesthesis. There are fractures in the posterior elements, and there is complete malalignment. The spinal canal, this is the spinal canal. You could see that, imagine that the spinal cord will be kinked, and this is to verify it on this. Same patient, and you could see that there is kinking and compression of the spinal cord. Better seen on the MRI. MRI gives more information about the ligaments. The anterior longitudinal ligament is torn here. The posterior longitudinal ligament is stretched here. The ligaments between the spinous process, the interspinous ligaments are all stretched and torn in this case because of the trauma. CT scan of the lumbar spine patient. Following trauma, you could identify a few fractures in the vertebral body, in the posterior element. You can again verify it on the axial image that there is a fracture in the lamina. Here, fracture in the lamina, fracture in the vertebral body, fracture in the lamina, fracture in the vertebral body. Following fracture, the part which is fractured is pushed into the spinal canal, causing compression of the cauda equina. When you talk about a lumbar vertebral body, the spinal cord finishes at the level of L1. So after that, there is cauda equina. There is no spinal cord. Spinal cord terminates at the level of L1. Then there is cauda equina within the lumbar region. So when there is a fractured vertebral fragment compromising the spinal canal, it is compromising this cauda equina. MRI of the cervical spine, last 5 minutes on it. Spinal cord, again, the same alignment. They are well aligned. They are all smooth curves. Various vertebral bodies identify on the axial image. You identify the spinal cord and various structures. You would also be able to identify the muscles. This is a blown up image. And you could see that these are the exiting nerve roots. This is the lamina, and this is the spinous process. And in the center, it's the spinal cord. In the thoracic spine, you could see the spinal cord very nicely. Vertebral bodies are all well aligned, and similar sort of thing as the vertebral body of the cervical region. Again, thoracic spine. You can see the ribs here, and this is the spinal canal. all well aligned. In case of lumbar spine, you could see cauda equina, because the spinal cord has been terminated at L1, you could see small little dots of cauda equina. This is how you can identify it. Again, they are well aligned and all in good condition. Same, again, a bit of pathology. This is a mass in the spinal canal. This is compressing the spinal cord. This mass is enhancing following contrast. You can see that the spinal cord is displaced posteriorly. This mass is intraspinal but extramedullary. Extramedullary means it is not arising within the spinal cord. So this is intramedullary, intraspinal. It is within the spinal cord and within the spinal canal. So this is intramedullary, intraspinal. Again, a bit of pathology here in the spinal cord, which is of high signal. Over here, the entire spinal cord is of high signal. So in conclusion, radiology plays an important role in diagnosing congenital and acquired disease of CNS. MRI is superior in diagnosing parenchymal disease, but time consuming and costly. CT is first-line modality in case of trauma, and CVA to diagnose or exclude hemorrhage. And that's the end of it. Thank you very much.